Welcome to VHIA. My name is Stuart McCullough. I'm the CEO of VHIA. The purpose of today is something that we've been doing with each of the enterprise agreements is conducting a forum to highlight the changes that arise from the new round of enterprise agreements. We were just thinking about this the other day, and in 2016 we had 5 major enterprise agreements to replace. That was a significant challenge for us as an organisation and for the people within it to get that work done within that period of time. But 2017 means that there are 5 major agreements to implement. And we know that that's a significant challenge for all of you. So part of what we're seeking to do with each of these enterprise agreements is ensure that we support that process as best we can through these EBA forums, through the development of implementation guides. I should say that this session is also being live streamed. That's a first for us. That's the first time we've had an opportunity to utilise that technology. But I will just say to those people who are watching us through the live streaming, the nature of the technology is that not only can you see us, we can see you. So Karen, if you're there, I can see you. You too, Mitch. What I will say for those of you who are live streaming, welcome. What I would ask that you do is that if you do have questions, that you can email those to me, to my email address, which is smccullough@vhia.com.au, and we'll be able to incorporate your questions into the session. We're very excited about the fact that we've got people live streaming as well. This session will be recorded and it will, like all of our EBA forums, ultimately be available through the VHIA website as well. The session today will be conducted by Tim Nagel. For those of you who are familiar with our podcasts, I've given Tim a lot of different titles during those processes, but today I'll give him the title of Manager of Industrial Relations. So Tim will be taking you through the major changes. But other than that, I think it's take it away, Tim.
Thanks, Stuart. So again, welcome everybody. So this presentation, I think as Stuart alluded to, this presentation is part of a comprehensive implementation support program for members. So it's not only the presentation, it's not only recording the presentation and placing it on our website, but it's also the implementation guide, including some of the frequently asked questions that we've done for the one-off good faith bargaining payment, and also the process that we've released. It also involves the maintenance of reference groups throughout the life of the agreement and the development of implementation issues, which we will use those groups to work through over the next few months. In addition to that, we've also added the community app platform to again be able to reach out to members and give feedback and be able to work through issues if they do arise. So it is part of a comprehensive support program, this presentation. So the purpose of this is to really give you an overview of the key changes to the agreement. It's not complete in terms of comprehensive about every change in the agreement, but we are covering all the substantive changes. I should just say at the outset, a big thank you for all those, and there are some in the room, who participated in the reference group through the bargaining process. We know that that was very difficult and very challenging, so we appreciate everyone who contributed, particularly Wendy, who supported us in person through a lot of the bargaining meetings. Your assistance was invaluable. Also Richard, who was also present during those meetings, and Alec, who will be joining us later. Thank you everyone for their contribution throughout the process. So just in terms of some of the background, so the VHIA, DHS and the unions have worked together not only in respect of the parties' new EBA claims, but also to do a number of things. The first one is to update the language and structure of clauses, to improve the logical order of clauses, so grouping things together where they should be grouped together, so allowances and leave types, these types of things. We should note that just with those two in themselves, it's created a significant restructuring of the agreement. And I think that everyone who's seen the old agreement and now seen the new agreement will no doubt appreciate that and the significance that has in the usability of the document. The other things that the parties have worked towards is the incorporation of the NES into the agreement, so things like requests for flexible working arrangements and a lot of the parental leave provisions that were contained within the NES have now been incorporated into the agreement. And we think that serves a number of purposes. Firstly, it makes it clearer, so it makes it easier to use because you don't have to work through multiple different source documents. And secondly, it also provides a comprehensive overview of what the entitlements are all in one place. So we think it's a worthwhile task. The other thing that the parties have done is cross-references clauses where possible. So we know that a lot of the clauses do interact with other clauses, so where possible we've tried to flag that and give the user a point in that direction. Finally, we've incorporated in this agreement, and I think many of us will probably be involved in the implementation of other agreements along the way from those 5 that were negotiated last year. We've included common clauses in this agreement as well. So those common clauses, for people who are not familiar with it, are procedural clauses that really should be consistent across agreements. That gives a number of advantages to employers and employees alike. Primarily, it provides the ability to have a predictable process to follow instead of having to tailor each process for the group of employees that you're addressing. For those who aren't familiar, those procedural elements or the common clauses are discipline, dispute resolution, consultation and redundancy. There are a couple of little differences for the mental health agreement in those common clauses, which really takes away from the term common, but we'll talk about them a little bit later when it comes up. I think the point to make, though, is that there's a lot of work still to be done in the mental health agreement. There's a lot more that we can do in terms of modernisation. There's a facilitative clause in the agreement that's a holdover from the last one. And in terms of simplification as well. So whilst we have come a little way in this round, there is still more work to do, which we will try and do over the life of the agreement so that it's not squished into the bargaining process. So in terms of the structure is not that different to it was under the previous agreement. So it's divided into 5 sections, and each of those sections have parts. So the 5 sections are common clauses, common terms, which is the same as last time. RPNs, PNs, PSOs, health professionals. And really the big difference in this is that the health and allied services portion has been separated from the management and administrative workers. Previously they were sort of intertwined. So like they've done in the general area, we've separated them out completely. We think that'll make clearer entitlements and make it a little bit user-friendly as well. The other thing that's worth noting is that we've made it clear in this agreement that the carer and consumer consultants and also the peer workers who are a new addition to this agreement are covered by the health and allied terms of employment, which I think previously there was a little bit of a confusion about that, so we've made that clear in this round. In terms of the commencement date, the 27th of April is when we started, and the nominal expiry date of this agreement is the 30th of June 2020. It's not like the nurses agreement that does have some wage certainty beyond that. This is a standalone agreement with no provisions that would extend beyond that date. Just in terms of, so we've got those 5 sections and they're broken into parts. Each of those parts describe a particular element of the agreement. So for instance, Part A deals with preliminary matters, Part B, consultation, dispute resolution and discipline. Part C, types of employment, end of employment, etc., etc., etc. Now, those people who are familiar with the other agreements that have been negotiated this round will start seeing that the same sort of method is being used to structure the agreements. Now, it's a deliberate strategy from us to try and make the agreements look similar and therefore be predictable for the user. So it's something we're going to continue to try and do and bring those agreements closer together, at least in structure. Overlaying that with the common clauses where possible as well, so that from a procedural perspective or a user-friendly perspective, the agreements are as useful as possible to the people using them. In terms of the structure of the presentation, what we'll do is that we'll walk through each of those sections and each of those parts, just highlighting the changes in each. Someone's obviously happy with the presentation so far. Beeping the horn. So the section 1 is common clauses, common conditions, sorry. And the first part of that is preliminary. So in terms of Clause 9, these are where the first changes are located. So what we've got is we've got a common definition of immediate family. Immediate family is one of those terms that are used at multiple points through the agreement, so a common definition up front seemed a good way to go. The other thing that's used throughout the agreement is relevance, or the term relevance. So we've also defined relevance as well, and that's got the same definition as in the General Nurses Agreement. The other thing that we've done is included a definition of peer worker. As people probably know, peer workers now have a classification structure within the agreement. We'll talk about that a little bit more later on. So the next part is consultation, dispute resolution and discipline. So Clause 18 is consultation. What we know about consultation within the sector from history will tell us is that they are the basis for a lot of disputes in the sector. Most of those disputes, strangely enough, are not necessarily based on what is being proposed, but on the process to follow to implement what's being proposed. So there was a focus during this round on trying to step out the processes during the consultation phase to reduce that disputation. So this is one of those common clauses that has gone across the agreements. What the clause does is it defines consultation as a genuine opportunity to influence the decision maker, but not joint decision making. And then we know that that comes from a decision of the Commission. But it's a really important framing of the clause is that it isn't joint decision maker, regardless of what may be put to us occasions. It is about discussion and consultation. The clause defines major change to be a change in the employee's program, production, organisation, physical workplace arrangements, structure or technology that is likely to have a significant effect on employees. So that is familiar, it's been updated in terms of the language and again consistent with the other agreements. The clause also provides for consultation on roster changes, which is a requirement of the NES as well, so that's been included for the purpose of completeness. In terms of where the clause is different to the other agreements, it's really different in two major ways. The first is that whilst the other agreements have indicative timeframes, they're not included in this one. What it does have though is a provision that says that the steps involved in the process are required to be undertaken in a timely manner, having regard to the circumstances. Now that provision is a hangover from the last one, and really it's saying members did have issues in terms of trying to get consultation process to progress. So this is a catchphrase saying that both parties have an obligation to progress it. And we know that that clause that's in the agreement continues to say that in the event that that's not occurring, early referral to the Fair Work Commission may be advisable. The other element in which it differs from the other agreements is that it has a provision that relates to consultation regarding significant effects where there's not a major change. And what this clause requires employers to do is to consult with employees in those circumstances before they implement the change, which is a departure from the other agreements. Now, I think this was one of the very last things that were discussed during the bargaining round, and we were very concerned about the inclusion of it. But in the words of the union, what it means is that not that people have to go through the whole consultation process, but people need to have a conversation, and that's how it was characterised during those last-minute discussions. The next clause, which is also a common clause across agreements, is redundancy and associated entitlements. The first thing to note is that whilst this adds provisions for redundancy and those entitlements, it has no effect on Section 97 employees. So Section 97 employees continue to be covered by organisational change provisions at Clause 20. And where those are the same as those contained within the consultation clause, the consultation clauses have no effect. So for instance, things like the disturbance allowance, which applies to Section 97 employees, is equivalent to a relocation allowance. So therefore they wouldn't get both. So in terms of what the clause does, it addresses a number of key elements for how people may mitigate against the effect of organisational change for their employees. So there's a range of things that can be done. For instance, redeployment. It defines a comparable role. We know that comparable roles have been a point of contention previously, so it goes and defines that. And it also includes that redeployment being not only across employers, but also into other clinical areas. And it gives us a process, the same as the other agreements, for determining that clinical area and what support may need to be given to the employee to assist them. Additional support to infected employees within that clause are salary maintenance for 52 weeks. Also, relocation is described in the clause as well, including what a reasonable relocation distance is. We know that in the past we have had discussions or disputes or heated discussions about whether across the road is a relocation or not. So that's addressed in this clause as well. Retraining is also addressed, and it's a common mitigation strategy used in the sector. And finally, termination of employment due to redundancy. So whilst the agreement doesn't prescribe what those redundancy payments look like, it does point people back to the government IR policy, which does contain both TSPs and also VDPs. The next clause is clause 22. So discipline is another clause that creates a disproportional amount of disputation. I mean, it's connected to unfair dismissals, so it's probably not surprising, but it does lead into a number of disputes. So the discipline clause is the same as the other clauses across the agreements. So those familiar with the nurses, for instance, that's been around since the last round, 2012, this clause is the same as that, with the additions that were added to the nurses agreement in the last round, just to clarify its operation a little bit. So that's in a number of aspects. So firstly, it defines performance misconduct and serious misconduct. It also confirms, like the nurses agreement, that first and final warnings can only occur in summary dismissal circumstances. It also provides an entitlement for a representative to be present at any time in the process. So the inclusions of those definitions, etc., is meant to help with the distinction between the investigation and the disciplinary process, which I think that some members have had a little bit of difficulty applying. So the next part is Part C, types of employment and end of employment. So this is clause 23. So in terms of, this is now a common clause. Previously it was contained in each of the sections. Now it's in section 1, common clauses. And it does a couple of different things. The first one is, being a common clause now, it removes the requirement to record patterns of work for part-time employees in advance and then only adjust it by mutual agreement. So that's a change for the our health professionals and also our health and allied services staff. And it also reduces the additional restrictions on health professionals' fixed-term contracts. We know that in the general area there's also some changes, but this one removes that as well. The next clause is retention, transition to retirement. This has been a feature of all the other agreements. We know that as a sector where there's a real focus on trying to keep people within the sector and trying to reduce those disincentives for people either reducing their hours or leaving prematurely from the sector. So what we've done in the mental health agreement, it did have the majority of those provisions already contained within the agreement, but they were scattered throughout the agreement. So we've located them in one position. They cover off all the things that we expect to see. For instance, the preservation of long service leave entitlement following a switch from full-time to part-time, so the red circling approach. Access to maximum 8 weeks of purchase leave by mutual agreement, and transfer to an alternative work location to facilitate retention. That third one's probably a bit unique to the mental health agreement, but the other ones will be familiar to people with experience across the agreements. And again, I think the key point to make in this area is that it is by mutual agreement. So these are about mutually beneficial arrangements between the employer and the employee. So if we continue to Part D, which is wages and related matters, superannuation. So superannuation is clause 29, and it does a number of things that we've already seen in the other agreements. So firstly, it adds employee choice of fund, And secondly, it adds superannuation payments for the primary carer taking long parental leave. So this is the 10-week portion. Not the short parental leave, not the old paternity leave, it's the long portion. The next part is hours of work and related matters. So here there's a change to daylight savings. So the effect of this is to align the treatment of daylight savings for all covered by the agreement, and really the effect is on the health and allied people. So the change is now that people are paid for hours actually worked. It was already the case for health professionals and nurses, but now it's also that for health and allied services employees. Part G is leave. So we've included a family violence leave, and people will be very familiar with this, no doubt. It's based on government policy position and a model clause that they've released, and it's the same clause across the agreements. And really the highlights of this clause, for those who aren't familiar with it, are that it adds a provision specifically for employees experiencing family violence, and it includes access to 20 days paid leave that can be taken without prior approval. That's prorated for part-time employees. It also provides individual support and allows an eligible employee supporting a person experiencing family violence to utilise personal leave as well. It requires the employee to identify contacts within the workplace who will be trained in family violence and associated privacy issues. And we know we've had some experience now with this over the last 6 months in other agreements, and we know that this is one of those areas that are probably the most challenging in the whole process. So the training for these guys, and also that confidentiality. So how we do protect people who attempt to access this leave, and how we restrict access to that information across the organisation. We know that this presents many challenges, especially in smaller hospitals where people are often more familiar with each other. So we've done a lot of work in terms of this. There is some material that we've developed in conjunction with the reference groups and in conjunction with some of the work that the Women's have already done. So there is a discussion document that's been circulated reasonably widely already about that. So we are getting down the track a little bit in how to operationalise this clause. The guidelines also outline what support can be given to those people who are accessing family violence leave through those contact peoples or their line managers. And we should note that those contact people aren't meant to be counsellors, they're meant to be the link between what the workplace can do and the individual who's experiencing that family violence. So some of the things that the agreement talks about that may be used to support that individual are things such as changes to span of hours or patterns of hours and or shift patterns, job redesign or changes to duties, relocation to suitable employment or alternative employment, and a change, even simple things like a change to their telephone number or employee email address, to avoid harassing contact. The next clause is long service leave. So clause 39. So clause 39 removes the loss of long service leave for termination resulting from serious or willful misconduct. We know that the previous agreement provided an opportunity for employers to do that between 10 and 15 years, but that's been removed, the same as the other agreements. It also enables the taking of long service leave in periods of 1 week. So it's about trying to make the access to that leave as flexible as possible. It also clarifies the operation of concurrent service as well. Concurrent service is one that's been increasingly causing some disputation over the lives of previous agreements, so we've included a provision that specifically deals with how that operates. Parental leave is the next clause, and that's a number of clauses altogether. I think parental leave clause gets the award for the most complicated clause in any agreement. But what we've done is we've tried to, at least, as I said earlier, at least try and include a comprehensive clause. It is long and it's complex, but at least we know that all the entitlements are in one place. The features of the clause are that adoption and permanent placement are now treated the same. I'm told that across Victoria last year there were 8 permanent placement orders, so it's not a common occurrence, but it is now treated as adoption leave for the purpose of accessing the entitlements within the agreement. The other thing that the clause does is it removes gender references within the clause. So previously, while we had maternal leave and paternity leave, now it's gender neutral and recognises the differences in some arrangements within the community. Again, it includes paid no safe job leave out of the NES, provides that process. It also adds provisions for breastfeeding requirements as well, including the storage of milk within the units. And it also allocates responsibility for that storage to the employee themselves. We know that that can be an issue in some workplaces. Part I is staffing. So the first change within this section or within this part is Part I, overlapping pay points, which is clause 47.5. What this says is that where an employee moves from one grade to a higher grade and the pay rates are less, the employee will be paid at the next yearly increment level upon appointment to the new grade. So in essence, and this will apply to circumstances like RPN 2 advanced or clinical specialist moving to an RPN 3 classification, for instance, that they won't go backwards, which makes sense. The last thing you want to do after your new promotion is drop pay, I guess. So this addresses that. The next clause in this section deals with community mental health discipline mix, and this was a very contentious clause, and not where we ended up necessarily, but the road to get here was very difficult for the reference group in particular. But this is where we landed. What the concern is and what led to this clause is a concern from some of the unions that the representation of nurses in community teams may fall for a variety of reasons, not least the significant increases in pay for nurses towards the end of the agreement. So this clause is about saying, well, if the percentage of nurses does decrease through the life of the agreement, then let's put in some steps to review that and what the implications of that would be. So the clause utilises a working group chaired by DHHS with participation from the unions and employers through VHIA to have those discussions and provide recommendations back to government. The figure that's used is a figure that the department collects, so on a yearly basis. So this is really a safeguard and the opportunity for the pays to review any unintended implications of a decrease in nurses' representation in those community teams. The other thing the clause says is that normal consultation processes are maintained. So if, for instance, an organisation was going to say that one community health team would change from all nurses to all some other thing, we would still need to go through a consultation process. One of the other significant issues within the mental health agreement that I'm sure kept not only us but members of the reference group awake at night is the community workload management system clause. So I think the first thing to note is that this clause has got a very rich history that started with, or not only started, but sort of a key milestone in the past was the government's release of a mental health caseload management standard in January 2011. And really what that tried to establish, and also through the last agreement, is for health services to implement community workload management systems. Now what happened, and for a variety of reasons, there were lots of challenges, but there were poor compliance with those requirements. In the last agreement, I think, and Richard would tell the war story with some gusto, is that there was very close to getting an agreement about a 45-55 split for community team members, but we didn't quite get there. I think it was travel time that created the issue. Well, this round we have got a community workload management system within the agreement. So in terms of, so there is a requirement in the agreement to implement a community workload management system within 12 months of the approval of the agreement. In terms of characteristics of that system, it says that a CWMS is required to apply the following in relation to each community clinician: direct clinical commitments of up to 60% of working hours, and organisational and practitioner development time of no less than 40%. So whilst last time we were working on a 45-55 split, the outcome of this is a 60-40 split. Each item that falls into those two different categories are contained within a table within the agreement as well. So they're transparent in terms of what they are. But we know that some people, especially through discussions in the reference group, is that some people have some difficulties. So there are some safeguards contained within the agreement to cater for those circumstances. So if an organisation thinks that the introduction of the clause will have a significant implication for the service, then they need to notify the parties within 8 weeks of the agreement coming into play. So we know that 8 weeks, if we do our quick maths, there's probably only about 2 weeks to go in that. So the good thing, however, is that we know through the reference groups that a lot of work was being done about some of the challenges in implementing a CWMS into the service. So we would expect that information will be sitting there ready to use. If people do notify that difficulty and the reasons for that, then people get an additional 6-month review process to see how they can meet the obligations under the agreement. That 6-month review process is overseen by the STPPWG. I think we'll get to that in a little while. But that is the equivalent of the same group that's in the other agreements. So assuming that group resolves those issues within 6 months, we know that the department is going to be involved in those discussions, then the organisation has a further 12 months to implement the CWMS. If there are any issues at the end of that 12 months, then then the parties will refer the matter to the Fair Work Commission. The Fair Work Commission can do a number of things. The first one it can do is extend the time to implement the CWMS by a further 6 months, or alternatively it can make some directions about what steps the employer should take in order to implement the CWMS. So it has an opportunity to consider what the circumstances are and make some appropriate recommendations in order to progress it for both parties. There are a number of exceptions to the requirement to implement. The first one is where there's a current CWMS in place that is compliant with the principles contained within the standards. And secondly, it also has a provision in there which preserves the status quo for those organisations which has a complying system with above 40% of that employee professional development time. So they're maintained under the agreement. The other thing the clause does, it allows the parties by agreement to vary that allocation. And usually where this will occur is for those more senior positions which have additional amount of time, for instance, that they need to spend supervising or whatever it may be. So there is some opportunity to cater for the individual needs of health services through this clause. So the next part in the common clauses, union matters. So the purpose of this clause is to really bring all union-related clauses into one place. It is also consistent with the provisions in the other agreement as well. So it provides things such as union access to employees for any process arising under the agreement. Now that may be a statement of the obvious, but it has been included just to make sure that that's crystal clear. The second thing it does is that employers will ensure that emails, electronic communication from the union and access to associated websites are not hindered. It's a little bit ironic that one of my emails to the union the other day got blocked, but under normal circumstances, this is just a bit of a safeguard to make sure that that those communications aren't inadvertently blocked. And usually what happens is that they go into a spam file, which mine did, and the person doesn't receive this. So this is about where that occurs, it being flagged and remedied at the earliest convenience. The next thing that it does is it allows the union to address new employees part of orientation or induction, as long as they have the necessary right of entry requirements. I think there was something made of the previous agreement with the distinction between address and attend, so that's been resolved in this agreement. And we know that that those processes are evolving within health services and changing. We know that some have moved to online inductions or orientations, for instance. So the agreement also caters for those circumstances and allows for those discussions to occur about how the intention of the clause may be fulfilled. It has the normal sort of provisions around notification of the unions about the dates if they're in advance and no later than 14 days before if they're not set in advance as well. And also, again, it provides the ability to agree to alternative arrangements. Clause 50 goes on to specify conditions relating to time off without loss of pay for union office holders and union representatives. It also provides an opportunity to take unpaid leave to attend a secondment to the union. And this is really about being able to try and build up dispute resolution skills that then can be brought back locally. The other thing the clause does, and it's a project of Stuart's, he's got very close to his heart, is a facilitative clause to try and raise the prospects of unions moving to an electronic notice board. At the moment, we've got the physical notice boards that are scattered through organisations, and there's always arguments about who accesses them and who doesn't access them, where they are. And so we know with technology changes that people have got the opportunity to message each individual on their personal phone and so be able to directly communicate with people. So whilst the ANMF have moved down that path, this is some encouragement for the other unions to also consider doing the same. The agreement, like it always has, includes a mental health implementation committee to work through implementation issues, and it lists a couple of priority issues for that, such as the family violence and the union matters clause as well. We know that that's exactly the same as the nurses agreement. The last matter covered by the union matters clause is around access to rooms for meetings. So this says that in the absence of agreement on a location for the holding of union meetings, the room where one or more of the employees who may participate in the meeting ordinarily take meal or other breaks will be the meeting room for the purpose of union meetings. And this is a direct reflection of what the Act says. So nothing in this clause is intended to override the operation of the Act. It is just what the Act says. Also within this section, or within this part, is clause 54, which is the service delivery partnership plan for the mental health agreement. So we know that government wages policy is that people had access to an additional 0.5% if they did enter into a agreed service delivery partnership plan. All of our agreements so far have contained one. They very much look the same, but there are some minor differences. So in terms of this agreement, it requires the STPPWG, very pleased with myself that I can say that generally well, to be established within 6 months of the agreement being approved. And that STPPWG will comprise nominated representatives from the unions, VHIA and DHHS, and it will progress the pay's commitment to improvements of productivity and efficiency. So it has the normal things in it in terms of improving patient treatment times, immunisation rates, reducing illness and injury through OH&S interventions. Probably the couple of things that are different in this agreement than the other agreements are that final point on the screen there that talks about collaboration with government to implement the 10-year mental health plan. The other thing that it includes is a process to try and reduce the volume and duplication of organisational, clinical, legal and reporting documentation. So the outcome of the STPPWG is recommendations. There's no mandatory obligations. Organisations don't have to do whatever is discussed or whatever comes out of that, but people can consider it whether it will suit them. The other clause that is in this part is clause 53, which is a reasonable adjustments clause, and this really reflects organisations' obligations under equal opportunity law. So it talks about an obligation to make adjustments to roles to accommodate disability where reasonably practicable. So again, it's a pick-up, and it's just more for awareness than anything else. So part K is occupational health and safety, workplace violence. So it also includes an industry OH&S working group. So this establishes an industry working group to develop and recommend measures to improve OH&S outcomes and around a number of different areas. For instance, safe patient and manual handling. We know that we've still got some challenges in this area. Safe rostering practices and prevention of fatigue risks. Occupational violence and aggression prevention. Employee management education for NUMs and ANUMs, and that's around those procedural elements of people management and workplace bullying as well. So that group will include representatives from those organisations. In terms of where we're up to, exactly the same provision is within the nurses' agreement. That group has met once so far and is doing some work. A key element of this clause and how it operates is going to be how to access the current expertise that's within the sector. Certainly, we've made a number of connections in the general nurses to not only the OH&S directors, but also clinical leaders within the field and the HR group as well. So really this process is about how we link in those expertise to inform that process. So we still need to work out what platform to use to try and make sure that as many people get to contribute as possible, but we'll be working through that over the next couple of months. So whilst the OH&S Industry Working Group very much looks at an industry-wide approach to the prevention and management of OVA, the OVA prevention and management is really a local approach to those issues. It is a replica of the General Nurses Agreement, so people would have already done a lot of work in this space. It has the same requirements for an action plan within a particular period of time. I think it's 6 months, and also a policy. So people would have already done that in terms of their obligations under the General Nurses Agreement. And what we would expect is that people would not have different plans or different action plans for different groups within the organisation. It would be one approach for everyone. So whilst this clause is contained within the Mental Health Agreement, we do expect that people have made significant progress in this area as it is. The next clause is OH&S management. This is a newer clause for the Mental Health Agreement. It didn't necessarily have these provisions in it previously, but these are the same as the Nurses Agreement. Actually, they're not as far as the Nurses Agreement. These ones just reflect the obligations under the various OH&S industrial legal frameworks. So it covers things like OH&S risk management, incident reporting, investigation, prevention, OVA reporting, designated work groups, HSRs, election and training, for instance, and workers' compensation, rehabilitation and return to work. That is the end of the first section, the common clauses. I might just pause there just to see whether anyone had any questions or any comments at this stage.
We do have a question from one of the people who's streaming today, so I'll just go through that question if that's all right, because I think it might be useful for everyone. So the question that's come in over the email is with respect to clause 42.41(14)(b), and that is it augments the transfer to a safe job requirement with paid no safe job leave. I just responded briefly to say that provision is not a new entitlement as such. It is an entitlement that arises under the Fair Work Act, and it seeks to replicate those, so it's no greater and no smaller than the national employment standard that exists specifically under sections 81, 81A and 82 of the Fair Work Act. But I just add to that in terms of the answer that we'd already given, that what the Act does and what the agreement does is it puts a heavy onus on providing a safe job where somebody has been certified as being fit for work, but that it's inadvisable for them to undertake their current position. I think one of the things that we've found, and I think some of the HR people in the room are nodding, that that's a really unusual thing to ask a doctor to do. And they're not necessarily accustomed to saying that someone is, they're quite accustomed to saying someone is fit or unfit, but saying that someone is fit for duties, but it's inadvisable that they would continue in their current role for some particular reason. So there's a heavy onus on trying to find a safe job for someone under those circumstances. In the event that that is not possible, then the Act then provides that there is paid leave for that person. That provides a pretty profound incentive to ensure that a person can be usefully utilised under those circumstances. But the reason for ensuring that that provision is in the agreement, what we found with respect to the parental leave provisions is that there was a fairly hit and miss approach under the enterprise agreements as to what entitlements were included in the document and which ones weren't. And so our approach this time has been to include as much from the NES around parental leave in the document, with a view to, if you are an HR person who is needing to determine what the entitlements are, that the answer will be in the document as opposed to somewhere else. There have been some instances where some things had been omitted from enterprise agreements. They were still entitlements because they were under the NES, and it was very difficult for managers to respond to a request where the answer wasn't in the document. So we've tried to make that more complete. But thank you for that question.
No, I think there's a really important point here, though. It would be very easy for someone to go and get a fit for work certificate from a doctor, but they were unable to do night duty.
So just in terms of, I'll just repeat that for the benefit of those people who are listening, not a question as such, but just an observation that there may be issues where somebody get a fit for work certificate during pregnancy, but say they're not fit for night duty. And I think one of the interesting things that some of the rules about how we engage with evidence under these circumstances are a little bit untested and unwritten. So we've got that provision that talks about them being fit for duty and it not being advisable. Is there scope, for example, for people to have some other examination or a second opinion? The Act doesn't really contemplate that at this point.
Well, I think we define safe, meaning safe for the baby. So it's not unsafe.
Well, safe for the parent as well.
Well, no, I'm being quite. I'm not saying that in a loose manner. I'm saying, what's an unsafe job? Is it unsafe for an individual to work in the evening? Does that create an unsafe environment for the individual because of their pregnancy? And that's how does it impact detrimentally on the child itself? I mean, the old safe workplace came out of VHP and working in we'll go on Bloomberg here. The way it was defined was that the environment in which the person was working was unsafe because they were pregnant. In other words, it was so hot that they couldn't, a pregnant woman would have detrimentally impacted her fetus while she was pregnant. So that's the old, definition of what unsafe is. So I've carried it through over the years that a safe workplace is one which doesn't create an environment that's unsafe for the fetus. And so I do have a very different sort of narrower distinction. So when you're talking about a safe workplace, it's how does that impact on the fetus itself? For someone to say, look, I can't work at night because, I'm pregnant, there are some issues attached to that.
So I'm not sure that we particularly, I'll just repeat that Michelle is raising the issue with respect to what does unsafe mean, and that it's specific to safety as a result of pregnancy. My observation with regards to that is the purpose of the entitlement, that it's about safety as a result of pregnancy, and that is what the medical practitioner is being asked to certify. I think the observation, though, just from a few of the disputes that we've had, is that is kind of unusual territory for the doctor. And I'm not sure how well or otherwise they're necessarily engaging with that obligation as such. And I take your point that there are times where the way it's being understood by the medical practitioner is broader. It's a challenge for all of us under those circumstances to make sure that the way it's done is consistent with the requirements of the Act, as opposed to something that's more in the eye of the beholder.
Any other questions or comments? No? All right, we'll continue on to Section 2. Registered nurses, enrolled nurses and psychiatric services officers. So within this part, we have the pay increments. So of course, from the 1st of October, there were some back payments, rates applicable from then. Included within that was the transfer of the ANUMs to Grade 3 Year 4 and Grade 3 Year 5 respectively. So the ANUM Year 1 went to Grade 3 Year 4, while the ANUM Year 2 went to Grade 3 Year 5. The next increment is the 1st of April 17, which is 3%, 1st of April 2018, which is 3.25%, and then the 1st of April 2019, which is a variable impact depending on what level of that the employee is. But we know that those percentage increases at that time are significant in terms of the increase. In terms of those changes in 2019, there's also a number of structural changes as well. So the RPN2 goes from 10 pay increments down to 8, and that involves collapsing the top 3 levels into a single level. The RPN3 converts to a 4 pay increment structure, and that involves the bottom 2 levels, so Year 1 and Year 2 collapsing into a single level. RPN4 converts to 3 pay increments as well in 2019, and that's a little bit more complicated in that it goes from 5 increments down to 3 different levels. So 1 and 2 get collapsed into a single level, 3 and 4 gets collapsed into a single level, and then the 5th comes the 3rd level. So those changes are all in 2019. The NUMs also go down to a single pay point, and so do the RPN7s. So I think in conjunction with some of the pay increases, this is what really sort of skews the increases or the percentage increases for some of those classifications as well. In terms of the PNs and PSOs, we have from the 1st October 2016 the CPD rolled in as it is for the RPNs, and also a 3% increase. And then we have yearly increments on the 1st of April of 3%, 3.25% and then 4%. So we'll just move on to Part A now, which is preliminary. So Clause 56 is a definition section for Section 2, and there's a couple of changes here that people would have seen elsewhere, namely in the nurses agreement. The first thing that's included is provisions that clarify for internationally trained nurses' experience once registered without conditions. So for that international experience to count, a number of things have to be present. Firstly, they must have been registered with the professional body in their home country. Their registration must be unconditional in Australia, and their paid international experience must be in a grade or subgrade at least equal or comparable to the grade in which the employee is employed within Australia. So a number of different things that need to be in place. We're doing a little bit of work currently with the overarching reference group just about trying to simplify that process as much as possible using the APRA categories of registration as a guide. So we're meeting tomorrow to progress that, and hopefully we'll have some more information out to people shortly. The other thing that happens there within this section is the method to calculate employees' anniversary date has been included, and that is that the anniversary date is the date the employee commenced work as a registered nurse or enrolled nurse following registration. So that anniversary date stays constant unless, of course, they progress into higher classifications. Part D is allowances and reimbursements. So the qualification allowance is Clause 71. And there's a number of changes within the qualification allowance provision. Double degrees and master's entry now recognised for qualification allowance. It still needs to be relevant, and it's not payable till 12 months after the receipt of that, 12 months experience, sorry. There's an additional qualification allowance inserted for doctorates or PhDs, which is at the 10% rate. Also, the evidence for higher qualifications has changed and aligned with the nurses in that it requires the employee to provide evidence of qualification that would satisfy a reasonable person from the education provider, such an award certificate or transcript. So we know that educational institutions have moved for various funding reasons into preferring to enrol people into master's degrees, and this provision recognises that partway through that qualification they're likely to be entitled to a graduate certificate or graduate diploma, so it enables the employer to pay on that basis. The other thing that the clause does is it just clarifies that the allowances are payable from the first pay period commencing on or after the evidence is provided. This is not to say that if people don't provide that evidence through CVs or at the time of appointment and that it's not paid, it's not back payable. But where someone comes out of the woodwork 7 years later and says, oh, by the way, I've got this, then it's only payable for the next first full pay period. So there's a number of changes in relation to nurse practitioners. We know that nurse practitioners traditionally didn't have access to Saturday and Sunday penalties, shift allowances or overtime, and that's historical based on that they were classified largely under management classifications, not clinical classifications, which was grade 4 and below, but the new agreement clarifies that they do receive those entitlements. In addition, the agreement, and this is for all agreements, we've put it into this section just for convenience so that we don't repeat it, but so all employees receive transport home following overtime where requested. Now, that's probably putting it a little bit too low, the bar. The actual entitlement is that when employees finishing any period of overtime at a time when reasonable means of transport are not available, the employee shall provide adequate transport free of cost. So there is a little bit of a bar that needs to get over. That's a commonplace entitlement for others. So what is new is there's some additional provisions that have been introduced to in the context of double shifts for the specific purpose of addressing fatigue-related issues. So what they are is that firstly it provides for employees in those circumstances to receive a 10-minute break, a 10-minute paid break every 2 hours for the duration of their shifts. And it also allows for that person to provide adequate transport home, including the return journey where the employee's vehicle remains at the workplace. So whilst we had an obligation to get people home safely, people returning to get your car acted as a disincentive and therefore placed people at risk because of the practicalities of those sort of arrangements. So the agreement's clear now is that it is a return trip as well to get the car to try and remove the disincentives to place a higher price on safety. Clause 78 is hours of work. So the roster for full-time and part-time employees in bed-based services and CAT teams will comprise minimum shift lengths of an 8-hour, 8-8-10 essentially. So Part F, public holidays, leave and related matters. So Clause 85 in the agreement really introduces, and same as the nurses, introduces a process for applying for annual leave and responding to applications for annual leave. So employees must submit a written request at least 6 weeks before the first day of the proposed leave period. And there is a bit of a caveat there that unless it's not unreasonable to do so, we know that the NES says that people can apply for annual leave at any time. And we also do know that annual leave requests can arise from unexpected circumstances. So whilst the process there is what we would expect to occur in normal circumstances, there is still some provision for those other matters. So then the employer will respond to a leave request in writing within 10 days. And that request may be that, look, we're not allocating annual leave at the moment for 2027, Christmas. We're going to do that closer to the date. Or it may be that, school holidays in 2047 is not being fully contemplated at the moment. But it will, in that process, tell them when the timelines are for that process. So we know that people, for instance, tend to roster Christmas later in the year. So that still enables people to reject those sort of applications on that basis where people are likely to also want that period of time. Where it is likely that the leave request will be rejected, the employer and the employee will consult on alternative leave days within the 10-day period, because we know that sometimes if I want from the 1st to the 20th, for instance, and I can't have that because of operational reasons or there's a lot of other people on leave, I may be able to have from the 5th to the 25th. So really that conversation is about trying to get some alternative mutually agreeable arrangements in place. If leave is not approved, the employer will advise in writing the reasons for the rejection. And again, the employer will not unreasonably refuse a request of annual leave. There must be a reason. When annual leave is approved, it must not be unilaterally changed by the employer. So I think that speaks for itself. The other item that's not there that is worth mentioning is 85.7b of the agreement. And what that talks about is the payment of leave, in particular where higher duties have been worked for an aggregate period of 3 months or more in the previous 12 months. And what it says is that in those circumstances, people will receive a proportionate amount of their annual leave at the higher rate. So that is also within this agreement as well, both in the nurses and also in the health professionals. We know that there is some issues arising from those provisions, and we're talking about that in the reference group this week to try and get some solutions. The next clause, 85, deals with excess annual leave. So we know that the previous agreements have all had sort of excess annual leave provisions within them, some more than others. What this clause does is it replicates the nurses' agreement and it provides a specific process for addressing excess annual leave, balancing the interests of employees, obviously, who often want to save it up for a particular reason, and employers who want to try and reduce the liability of the accrual. So it says that where an employee has 2 years or more of annual leave entitlement accrued, the employer may direct the employee to take some of that accrued annual leave with at least 2 weeks' notice, provided that a reasonable opportunity to submit a plan to reduce the leave to not less than 8 weeks within 6 months has occurred. And the employee will not unreasonably refuse to agree to a leave reduction plan, which includes saving leave for an extended vacation within 12 months. We know that overseas trips is the biggest one of the date of the agreement to the leave reduction plan. So that agreement is to be in writing and signed. So it provides a process for managing leave. And I think if you map it out, then there'll be obvious key points in that process where employers will want to monitor and take particular action in order to make sure that the process occurs in a timely fashion. The next clause is personal leave. We know that in the previous agreement there was a very peculiar personal leave clause that allowed for paid personal carer leave accrual in the first year of 121 hours and 36 minutes, the second year 136 hours and 48 minutes, and up to 191 thereafter, I think 5 years and thereafter. And it also contained those amounts that we see commonly across the other agreements. The previous agreement at 54D said that unused personal carers leave accumulated from year to year. So there was a real anomaly in the previous agreement about the quantum of accruals and whether they were carried over or not. So that has been resolved in the new agreement. So what clause 85 says is that those leave accruals accrue at the normal rate. What happens is there's an additional amount of personal leave, compassionate leave contained within the agreement, and people are able to access that if they exhaust the other entitlements. Most importantly though, what the agreement says is those additional leave amounts do not accrue from year to year. Is there any questions before we have our interval? Rhonda?
Just on that one, so every year I can get an extra 30 hours and 24 minutes.
That's right.
So I can use all my leave and sick leave for that year and then get another 30 hours.
It has a fairly strange and interesting history, and I know that some people in the room are familiar with it.
I think Stacey's got some scars from it.
Yes.
I would say most of our staff don't know about it, because I know I've requested it.
And
So
look,
in terms of the basic history of it, there was a period of time in which the personal leave and compassionate leave provisions were all in the one clause. And that's where that additional period of time came from. At a certain point along the journey, the compassionate leave provisions were separated out of the personal leave provisions. And yet that additional amount of time still sat within the clause. It's been a point of agitation. I agree with you. I think most people are unaware of its existence because it doesn't make any sense. But it was a point of agitation, and it was necessary to find some way to conclude it rather than simply push that ongoing skirmish further down the line. By confining it to a circumstance where people have exhausted their leave, by making it clear that it doesn't accumulate, has effectively confined that issue.
So, especially compassionate leave, so, because unfortunately as one gets older, more of your relatives, grandma, grandfather, plus die. So you can take 30 hours compassionate leave every year then.
But there's no limit to compassionate leave. You can have as many occasions as you need.
Yeah, but still say,
It's
So
a
this is
bit-
actually for personal leave, as in sick or carers.
That's a good point. Just for those people who are listening, the query was with regards to how does that entitlement apply in the context of compassionate leave. The observation has been made that compassionate leave is event-based without a cap as such, save for the fact that there is a cap for the amount for each individual circumstance. I'll just check and see if there are any queries from online. Oh, just another question from one of our people listening through the streaming. The query is with regards to paid a proportion of the higher rate if the employee has worked at a higher rate for 3 months or more in the previous 12-month period. That issue is, the query is with regards to the annual leave where somebody has worked higher duties for more than 3 months, and whether or not the time worked at higher duties needs to be before the agreement commenced. I have my view. Tim, I don't know if you want to venture a view first.
I'm happy to go second, I think, Stuart.
Okay. With that being the case, that's a really great question that's been put. The agreement takes effect from the date of operation, and I think the appropriate time is to treat it as the time the leave is taken, as opposed to when the higher duties were worked. That is, it wouldn't be a matter of saying, did you work your 3 months of higher duties only after the operative date? You would be making that assessment at the time the leave is taken, which will inevitably at this point be after the operative date. So hopefully that answers that question. I'll put it over to you if you disagree.
Hello, happy to go with that. Is there any other questions?
Josh?
I just had a question about the wage increases and the reduction in the increments. What was the rationale for that, and why was that?
Which one, sorry?
So the reduction in the number of increments with the RPM, so the wage increases. I just looked at it and thought, what's the reason for that?
I'd say to probably align to the general nurses.
So the query for those who are listening was the rationale. What was the rationale behind changing the number of increments for some of the RPN structure? And the answer was alignment with the general nurses. Thank you for that query. All right, with that, we might take a break. One more question?
Just one more. High qualifications, the EBA's gone from two qualifications to now 4.
Health professionals?
Yes. So so both certificate and the postgrad were one qualification, one payment. But now that they've split those into 2, certificate, we have 13 people that will go backwards. So I'm assuming we grandfather?
Yeah, that would be the
I would
expectation.
thought so, yeah, that's good, yeah.
So I'll just repeat that question because it's a good one. The query was with regards to those people who had a higher qualifications allowance that was greater than is now prescribed under the new agreement, and whether grandfathering would be an appropriate course, and we've agreed that it is. So just for the purposes of taking a break, I think 15 minutes. So for those people who are streaming, we'll be back on air at 10:45. I will provide an assurance that Tim and I will be disconnecting our microphones for the next 15 minutes. We'll be back at 10:45. Thank you. We might make a start with regards to the second part, which I think it's fair to say, Tim, that the second part is slightly shorter than the first part.
Correct.
I am assured that there will be some light refreshments at the end of this session. So my apologies to those people who are streaming. We'll post those sandwiches out to you at the first opportunity. I will say that once we have completed this session, you'll receive a survey from us. And we'll be seeking just your feedback with regards to today. That's just part of our process so that we can look to make refinements to some of the things that we have started to do with regards to EBA implementation so we can improve our processes. But to kick off for the second half, I'll hand it back over to Tim.
Thanks, Stuart. So we'll continue section 2, and part G is the next section, education and professional development. So the changes within this section are as follows. So clause 89 provides for professional development leave entitlements. The first point of the first change is that preferred professional development for individual nurses need not take place on the day that the employee would otherwise work. So they've got options to take their preferred professional development that's occurring on their day off. And this is really to try and enable people to access those professional development opportunities which will best suit them and therefore the employer as well. And there's a number of different ways that can occur within the agreement, and it provides a list of options such as allocation of a day's professional leave paid at ordinary rate of pay, so they just get paid ordinary rate of pay for that day, time off in lieu on a mutually agreed day, or an additional day's annual leave, which will not attract annual leave loading. So there's some options built in to the agreement to provide flexibility with how that may occur. The other item or change within this part is that nurse practitioners are entitled to a further 10 hours of paid professional development leave per annum, and that's the same as the general nurses. And also that professional development leave is available only on application by the employee and at the sole discretion of the employee. There's a little bit of contention from the unions that people are being forced to access their professional development leave for mandatory training, etc. So this was in the previous agreement, but it's just been highlighted a little bit. The next part is examination leave, and really examination leave has been updated just so that it can cater for non-traditional examinations. We know that educational facilities are moving into non-traditional assessments, so this just caters for that transition. So it says that examination leave may be taken for major assessment tasks, take-home exams and other methods of student assessment. It's not such a big change to the mental health agreement because we also had words that could have been interpreted to that effect, but this replicates the general nurses agreement provisions in their entirety. The other thing that's not in that slide that has changed and it's worth noting is that access to study leave, which used to be subject to an organisational policy, has been replaced with that it's subject to operational requirements. So just a bit of a change just in the wording of that provision as well. Part H deals with classifications and staffing. So the first item there is nurse unit managers at clause 91. So the 91.1 deals with nurse unit managers and provides for one EFT nurse unit manager to be appointed at each ward or unit of all residential and inpatient services. Now that is the same as what was in the previous agreement, but there has been on occasion non-nurse unit managers used in some of those facilities. So we've just added a clarifying statement to cater for those arrangements, and that is that subclause A does not require the appointment of a nurse unit manager in a CCU or CRP or other title where a NUM is not appointed as of 1st July 2016. So it preserves those non-nurse appointments as of that date.
Does it just preserve the non-nurse appointment for that individual or for that unit? So if that non-nurse leaves and we are recruiting a new manager, does it have to be a nurse, or because it's preserved? Because it doesn't. I don't know that that's clear in that exact wording.
So Stacey's just asked whether the appointment of a non-nurse unit manager in a particular CCU is preserved just for the appointment of that employee, or it therefore carries over to the next employee as well. My recollection is that it carries over to the next one as well. But what I'll do is we'll just post that answer on the app once I've clarified that. The next clause deals with high dependency units, another vexed issue during the negotiations that the reference group members will have feelings of dread recalling. So what this clause does is it amends the numbers of staff within HDU. So people recall that the previous agreement said that at least 2 nurses are allocated in HDUs where there are 4 or more patients. So what that meant is that you could have a 1-to-3 ratio in particular HDUs depending on the occupancy rate. What this agreement does is, in conjunction with the additional EFT allocated to the mental health agreement of about 128, a significant portion of that has been allocated to high dependency units for the purpose of increasing the ratios within those units. So the new ratios is virtually 1-to-2, and it increases as the beds increased, as per that table.
Just a question. Sorry, just a question that's come in through one of our people who's streaming with regards to the same clause that Stacey was raising, and the question is a NUM required to be appointed as a separate position for a 4-bed unit, such as a PAPU unit, or can they also be a NUM for the inpatient unit also?
I think that it depends on the specific circumstances, and really it depends on how the unit operates and also how it's geographically situated. So those units are contained within an inpatient unit would lend itself to a combined management structure. But if they were significantly geographically isolated or separated, then you would think it's probably 2. So it will depend in part on the specific circumstances. Certainly if they're co-located, yes, the answer would be.
So just in terms of unit, that term is not defined?
No, that's right.
Okay, so just what that means is there's flexibility about how those things are configured, but taking into account the kind of considerations that you were outlining?
Yes.
Okay, thank you for that question.
So the HDU table is subject to the additional allocated EFT set out in Part B of Schedule 10 within the agreement. So what that means is that you don't need to comply with those ratios until the additional EFT is allocated, and it's staged throughout the life of the agreement. But it will be fully operational by the 1st of September 2018. What we were careful to do through the reference group and also during the negotiation process is to ensure that the clinical team leader maintain the ability to reallocate people in accordance with clinical needs. So people can be taken out from the HDU and allocated across the unit if there is a clinical need to do so. So that's been preserved in the new agreement. The other additions to the agreement are insertion of a specific consultation liaison nurse provision, which describes the role as an RPN 4, and it gives an outline of some of the tasks that it may perform. The things that it does say is that it's a 7-week position, and also that there's a minimum of 1 CL nurse to every 300 beds within a hospital service. That they're not obligations, they're aspirational statements. So we should not be led to believe that they're requirements of the new agreement, because they're not. The other thing that the agreement does is introduce a PN4 enrolled nurse education support role within health services. I think Michael's the proud owner of one already, but there are 3 others that are part of the 128.8 EFT allocation through the life of this agreement. They'll come online from the 1st of July 2020, and there'll be one funded position in each of the mental health training and development clusters, and they'll be employed by the lead agency within that cluster. So that concludes section 2. Is there any additional questions or comments people had about that section?
Where's the other two clusters, where the other two going?
So there's 3 clusters, 1 to each cluster.
Yeah, so where are the other 2 clusters, what are they, sorry? Yeah, one, what's it, I understand the Melbourne Health Cluster, but.
So Melbourne, Monash, and the third one is Barwon.
Thank you.
Any other questions or comments? No. So section 3, health professionals. Now it goes really quickly from this point on. It's like a slippery dip. It just sort of falls away very quickly. So in terms of the wage increments for the health professionals, from the 1st of October 2016, we've got a couple of things happening. Firstly, alignment with public sector rates, rolling in of CPD, and then 3.25% on top of that. And then we've got increments November of each year for the next 3 years of 3.25%, 3% and 3%. This is on top, obviously, of the good faith payment, back payment. Part D is allowances and reimbursements. So 108 deals with higher duties allowance, and this has been included for the purpose of where there's multidisciplinary teams. If the health professional is in charge, then they're not paid, or if they're the shift leader, then they're not paid any additional amounts, whilst a nurse would be. So this is to rectify that sort of circumstance. 11.4 also, as Rhonda said before, has been amended to include a graduate certificate level and also a postgraduate diploma or degree level as well. And that really mirrors the nurses' agreement. Part of the flavour during the negotiations arising out of the multidisciplinary nature of a lot of the mental health services is parity with those nurses and having some common conditions with them. This is an example of some of those. The next part is Part E, hours of work and related matters. So the significant change in this area is the change in till for health professionals. So it's now taken, like the nurses, at the penalty rate, so time for time, as opposed to hour for hour. So if you did an hour's overtime, you would take an hour and a half till instead of 1 hour. The next part is Part G, leave and public holidays. So under the new clause, and we have the same, I should just note that the annual leave clause for health professionals is virtually the same as the nurses. In fact, through the negotiation process, we had tried to make it a common clause, but we separated it out towards the last just because of the distinctions in the quantum of the leave. It was a bit difficult just to draft it. So in terms of those references before that we had to the procedure to take annual leave, management of excess annual leave, they're the same for both the health professionals and for nurses. The distinction, though, is in the quantum. So whilst the nurses have 190, the health professionals have an increase to 170, which is the 4.5 odd weeks. They've offset that in the negotiations by a number of things. Those are, there was a bit of the CPD allowance left over from the rolling in to achieve the rates equivalent to the other groups. So that's been incorporated in the additional annual leave, so as an entitlement to 2 days conference study seminar leave, and also the public holiday penalty rate reduced to 200% on the weekends. Whilst they've got they've got access to that 4.5 weeks, they've also got an opportunity under the Act, under the agreement, to purchase an additional half a week's annual leave, so they do get up to the 5 weeks. So in order to obtain 5 weeks of annual leave, the employer may elect, and an employer can't refuse, to purchase additional leave totaling not more than 2.5 ordinary days' work. So this gets them to their 5 weeks. Like we said with the nurses before, also, and in accordance with the similar annual leave provisions, the health professionals also have access to annual leave at the higher duties rate where they've performed the aggregate of more than 3 months. The next part is Part G, education and professional development. So clinical supervision is clause 138, and again, this was to seek parity with nurses, and it provides an opportunity for health professionals to access up to a maximum of 2 hours per month professional clinical supervision. And it has the same provisions around that choice in terms of who provides that as the nurses agreement. The other item that's not up there that's either clarified or changed, depending on where you sit, is professional development leave. So that's provided to full-timers, but it's also clear in the new agreement that that's also prorated for part-time employees as well. And that's clause 133. So that's section 3. Was there any questions about section 3 before we move on? So section 4 is health and allied services. So in terms of the wage increases, they're the same as the general. October each year with rates of 5, 3, 3 and 3. What has been introduced into the mental health agreement is a multi-skilling allowance which replicates the allowance in the general agreement. And it is paid in recognition of the need to work flexibly and perform incidental peripheral duties across multiple discipline roles and areas within the provision of patient services. So it's paid on the 13th of November 2017 and then of $1,000, and then on the 13th of April thereafter at the rate of $500 per annum. And it's paid to all employees classified as PSAs, prorated, etc. Same rules as the general agreement. Part I is classification and staffing. So under this section we've got two things. The first one is a clerical reclassification process. So it says that mental health ward clerks aren't such much an issue, but it's more the community team clerical workers who regularly during the course of a shift have contact with patients and clients are required to be reclassified to a clerical worker B. So these are the receptionists and the community teams, etc., the ones that have face-to-face contact with our clients. The other thing that the clause does, clause 193, is it deals with a clerical review. So payers agree to conduct a review over the next 12 months to properly record and define the work of mental health ward clerks and community team clerical workers. And this sort of fits in with the clerical review and the translation process that occurred in the Health and Allied Services Agreement. So there has been a 1A inserted into the mental health agreement. So the outcome of this review is whether there's any translations, and if there is any translations, what those translations are.
And is it a central review or is it an individual health service review?
It'll be a central review, yeah.
Just repeat the question.
The question was whether that clerical review at clause 193 would be a central or a local review, and the answer is that it will be a central review. The other change in the agreement is to carer consumer classification. So a level 3 has been inserted within the schedule. The role is described at that grade 3 or that level 3 as being positions at this level are regarded as senior positions within the carer consumer consultant framework that oversee a small to medium-sized work group, and that they possess lived experience, etc., substantial expertise in the area. So it's creating a new level 3 within the carer consumer classification structure. So the other change to the structure, or the classification structure, is in relation to the insertion of a peer support workers structure. So it's a 3-leveled structure, with level 1 being entry positions working under direct supervision of clinical staff. The level 2s are not working under that direct supervision and independently operating. And then we have the level 3, which is the managing a team of peer workers. We're on the run home now. So section 5, was there any questions about section 4 that anyone wanted to ask?
Is there a time frame on clause 192 with respect to reclassifying those receptionists and other staff to clerical worker B?
No, I think it's the commencement.
Just repeat the question.
So Michelle just asked whether there was a timeline on the clerical workers reclassification, specifically those who had direct contact with clients, and the answer was no. It was from the commencement of the agreement. So just in terms of the wage increases, They're the same as the general, being October each year, 5, 3, 3 and 3. And that is the end of the presentation. Any questions, comments, thoughts?
I think I have one for this group. This is the second agreement that we've had which has provision for health and allied health professionals and the like, as sort of separate pockets that exist within that agreement. And I'd just be curious to know how people found that experience of having a group of health professionals, some of which are under this agreement, some of which are under a general agreement, health and allied services employees, some of which are under a mental health agreement and some of which are not. What's the experience for you as practitioners in trying to administer that?
I mean, the difficulty arose when they first split out, because that was where all the work was.
That's where the pain was, is when they first split out?
Different groups under the two agreements. I think the issue now is there's inconsistent entitlements.
So just the comment about that most of the work was when they were originally split out, which was a feature of the last round, but they're noting that there is a change or difference, a growing difference in the entitlements. I'd make the observation that during the course of the discussions, there were moments at which having the exact same entitlement as the general agreements was very, very, very important. And then there was suddenly a moment when that principle was not very important at all. And that does create it creates an interesting issue as to whether to seize upon that difference and to make them completely different, or to seek to get them consistent across the board. Sorry, Wendy?
There was the inclusion of another union. HACSU were not always on the same page as ANMF on that whole notion of getting common conditions across all in the mental health agreement.
Yes, very much so. Very much so.
I might just a quick comment, just back to Michelle's question before about when that clerical review commences. It's from the certification of the agreement, not back to October, just to make sure that there's no, so they wouldn't be back paid to October. It's just from the date the agreement commences.
So okay, the question, because we haven't started that exercise yet, so that's the important point. And my question was, did we have a time frame in which we had to commence it?
No.
But you're saying no, but we'd still have to make the back pay payment back to them.
Commencement of the agreement.
So that gives it a sense of urgency.
Right.
Are there any other questions or queries or observations with regards to this? So I made the point before that we would be sending out a survey with regards to this experience. I think one of the other challenges for us is once the dust settles to think about how we evaluate the implementation tools that you've been provided, and to see where we can develop those further if that's of use. I am assured that lunch is in transit and is about 5 minutes away. We would love it if those of you who are here could stay with us and grab a bite to eat when that arrives. But other than that, I would like to thank you very much for your attendance and participation today. And thank you to those people who streamed as well. Thank you.